Hi, my name is Karen Harris, and I've been a physical therapist for the past 19 years. I started off working in neuro rehab, but through the entire course of my career, I've been working with pediatric patient populations. I'm going to go ahead and get started on Evidence in Motion Pediatric Physical Therapy course, and I'm going to start with the role of PT in pediatrics. Our role is to achieve the highest functional level for the child. We want to make sure that we are also promoting the best postural alignment. We want to improve range of motion, strength, coordination, functional mobility, gait, and symmetrical movement patterns through both direct treatment and home program. Reduction, prevention, and minimization of pain, contractures, asymmetries, and joint deformities that will limit child's function, and identification of splinting, bracing, and therapeutic handling, support, DMA, and positioning to increase the child's independence. We also assess and improve accessibility within the home and the community. We're problem solving with the family to improve ease and safety with transfers, functional mobility, positioning, bathing, and toileting. We're really key in identifying equipment needs, especially seating systems for the wheelchair, the walker, bathing, toileting, equipment for increasing their independence within the home and community. And assessment and heavy emphasis on caregiver instruction with return demonstration by that caregiver. And we have to remember also to frequently review and modify the home program as needed. We are also trained on body mechanics with transfers, transitions, functional mobility, and ambulation. Wow, that's a mouthful, but that's what we do to help these kiddos. As far as a general working knowledge for PT working with the pediatric population, really memorizing and knowing the first 12 months of gross motor development will help you with this patient population. That memorization, understanding the process of how that development goes, it will help you across the board, whether you're working with pediatrics or even just working in any type of neuro rehab also. Understand also the general development of postural control, and also that you have available a reference of gross motor development for older than 12 months. So what I mean by that is that you would have just a reference there that you can look to know what they should be doing at 2, know what they should be doing at 3. And I have a document that lists out those general guidelines for you that hopefully can be a resource if you have a pediatric patient come in, to know general guidelines for gross motor skill acquisition, and that you also understand the stages of gait with new walkers and the development of gait, that they begin in the high guard position in the upper extremities, and then they go to mid guard, and then they bring their arms back down, and at first they're a little bit up on their toes, then they start coming down onto flat feet. Their stride is real short and limited at first, and not very well balanced, but that you just generally know what it should look like at first, and then be able to observe and assess proper biomechanics with motor skills. My meaning this, you need to be able to observe and see how the child does things, so you're looking at the alignment and how they perform it. So that takes practice in observing people and how they should move. These children do not start with normal development when you're dealing with the neurologic diagnoses. So you have to be able to assess their biomechanics. Have gross motor testing available for 0 to 12 years of age. If you don't have standardized testing at your site, at least have something that you can go to so that you can compare them to typical developing children in helping you develop a treatment plan specific for that child. And then also you need to know how to engage the child depending on their age. You know, baby is going to need toys that are light up toys and music and things like that. An older child just needs you, you know, 5-year-old, they need to have activity that will engage them, you know, ball tossing, um, simple games. And then the older children, 7, 8, 9, 10 years old, they will do what you tell them to do in an adult setting, but they will engage a lot more if you have the sport activities or something to make it fun for them. And then the toddler stage, I'll go back, you know, bubbles, star stacker, uh, pop-up toys, those things work with those children to engage them. And then you need to know how to get cooperation from the families and the children. Get the families to buy in with what you're doing. You'll have a much higher functional outcome. And then your considerations prior to the initial eval, you need to think of the age of the child, the referring diagnosis, and then when you're in the session, oftentimes you'll have one treating diagnosis, but in the session you will come up with the actual treating diagnosis for the child. I try to observe in the waiting room to see a functional level, are they able to sit, are they able to stand, are they able to walk, and because sometimes I do not have all that information available to me in an outpatient setting. Um, Family participation, you want to consider that, and you want to consider also their cognitive communication level. That will have an impact. And then any other medical diagnoses, heart conditions, cancer, they can just cause you to modify or even disregard certain testing that you might use in certain situations. Like, for example, if someone just recently got a G-tube, you may not be able to put them in prone and assess their head control. So you have to consider that, or recent heart surgery. So those are things to think about. If you have medical reports available prior to the evaluation, you want to review them, and just like you do with any patient who comes in, reviewing all reports that are available. With pediatrics in the neurologic realm and the areas that I'm going to focus on, there's usually multiple medical history. So having that reviewed and an understanding will help you in preparing you for the evaluation and treatment. Oftentimes, like I said earlier, you receive little to no information. So you have to be good subjective interviewers with the families, because oftentimes I've had situations that, for whatever reason on the questionnaire, that heart condition that was dealt with early on wasn't noted. And it may not be relevant, but it ends up coming up in the subjective interview of trying to pull out information from the family. And then prior to the evaluation, try to choose an area set up for you. If they're, you know, a new walker or they're crawling, you want to set up an area that you can observe them pulling to stand or cruising along surfaces, and having toys on different levels so you can observe those activities. So just like when you get a new patient and you know they're close to their functional level, you want to have areas that they can transfer, or so you can observe what they're able to do. And your introduction to family and the patient in pediatrics is key, because you're really developing the trust with the family and trust with the patient. And trust with the patient or the child doesn't always come at first, but at least if you can get it with the family at first, that's going to help you immensely in your treatment. So usually family caregiver is your initial contact. You know, you want to be really friendly and smile and be happy to greet them and just confident in your ability. You know, if there's a dad there, shake the dad's hand and try to make eye contact with the child, no matter their functional level. So if they're even in a chair and seem to be nonverbal, you at least attempt to make a conversation with them. You want to regulate your height and voice specific to the age of the child. You don't want to be hovering and standing over a small toddler and they look up at you and they're completely intimidated. You want to bend down on one knee and smile at them and ask them, you want to come play? You know, you want to phrase it in a way that would be encouraging to the child for them to come with you. And if the child has any asymmetries, you want to maintain your composure, even if it's an asymmetry that you've never observed or seen or was unexpected, because this family has probably experienced, you know, multitude of reactions, and so they're looking to go to a place where no one will judge them and would like to have a therapist that would trust them, that they can trust and will not make them or their child feel uncomfortable in any way. So, and one suggestion I make usually is if you're seeing that for the first time and you're inside, you're going, wow, you know, or even you're thinking, wow, that's kind of cool. You don't want to ever say that. And I have a funny story. I had a student that saw, well, not a student, she was a therapist. She saw, though, she just hadn't seen Clonus. So she saw Clonus, and I'm showing her, and she kind of said, that's cool. And I thought, oh, you know, you don't want to say that in front of the family. But the family was totally fine, didn't even notice it all. And she was able to establish rapport really quick with the family. So anyways, that's just something to keep in mind, to try and control your reactions. But you want to build rapport with the family by just commenting, try to find something positive about that child or about the family, or make conversation about, how did you get here? Or, wow, I'm so impressed. How did you manage bringing everything in? Something positive for the family that will just kind of break the ice in conversation. You can ask them about what they do for a living, and you're doing all this to establish rapport and open communication, and then in that you can find out other things about the family history. You can find out about the siblings. You can find out, does mom work? Find out, what does the dad do? And all these factors contribute to their ability to participate in their child's program. Then on to, I've kind of already gone over about subjective interview. You want to do it as conversational as possible, and you're looking for certain information. So you're looking for the family's primary concern and their goals. And also you want to know what they want from PT. And usually if they have been kind of overwhelmed in the medical setting of having multiple people, believe it or not, even if they've had PT, OT, speech, everything, they oftentimes don't even know what a physical therapist does because they've had all these therapists thrown at them. So at that point, usually you will explain what a physical therapist does and how you can help them. And then that usually helps to open the door of what they want for their child. Because if I ask just an open-ended question, oftentimes they'll say, oh, I want them to be able to talk. And then I have to go back and tell them that I help them to walk and move. I don't necessarily help them to talk. Well, I'll encourage it in the session. I'm not a speech and language pathologist. And then you want to ask about the prenatal, postnatal history, pregnancy, medical, general health of the child. And like I said earlier, you're finding out about the family support and other siblings, and if one or both caregivers are working. And then You also want to focus on family concerns as a guide to where to focus in your evaluation. When you have a child that's total body involvement, you want to gear your treatment plan exactly where the family wants it. And then in a child that's more simply involved or less complex, you want it also to be geared towards what the family wants, because you'll have better buy-in and participation in whatever you suggest. And so in some occasions, that actually may be different. You'll discover as you assess the child, it's different than the referring diagnosis. So you have to go through the process to make sure the correct treating diagnosis is on that child. And try to have as many open-ended questions as possible, even while you're beginning to assess the patient, so that it'll just help bring out, other things that will help the patient, or even barriers to treatment. And there's significant information that often parents come in and assume the referring physician has communicated it to the therapist, and it's not communicated anywhere. So asking lots of those questions will really help you. And possible barriers to treatment. You want to understand the stages of grief, especially with a severely involved child, and where they are. When we get them real young, oftentimes they are in a denial stage and, just think they're going to snap out of it. So they might not buy in completely to the home program. Then they can move to an anger stage, and that's a stage that you might experience them getting frustrated with you if you try to push them and move them in a direction that you think they need to go for their child. You might get resistance, or you might even get criticism. You need to understand that they're probably still going through stages of grief, and so review those so that you're aware that that is a possibility. Other barriers are lack of family understanding on how to interact with the child, family fearful of hurting the child with exercises or moving them. We find this a lot with torticollis or Erb's palsy, where the parents have to be very consistent in their range of motion and positioning program, and that babies do not aren't always very compliant. And then family over assisting a child or overly protective. Like when a child is learning to walk, you need to allow them to fall safely. You need to practice those things. So a parent who has, for whatever reason, just wants to guard them from that, they can be overly protective, and you need to address that with them. The family also could be intimidated by a medical setting. We've had families that are very kind of stay back and seem like they're disconnected from their child, when in actuality it's really the setting. So try not to make judgment calls on the family. There's a building of a relationship that you'll discover what is really going on. And then we have families oftentimes that say they'll follow through, but there is no follow through at home. So that's a barrier too. And then behavioral outbursts from the child will always impede your treatment. But sometimes parents will say, "Oh, they're fine at home." So, you don't always know if that's true, and you try to just say, "Well, show me how you do that." You ask them to demonstrate. So return demonstration of whatever you're asking them to do is key to document and have the parents perform, not only to know that they're performing it correctly, but then too how they're doing it, and are they stretching them adequately. And considerations for assessment. Sorry, I skipped one. I skipped objective. Considerations during objective. As in orthopedics, you're looking for a sign. You try to grab onto one major area of function, and then you also want to use some, look at alignment issues, look at range of motion issues. That will help to be your objective findings and indicators that you can track for improvement. You can get a child that's totally involved, but yet make small little progress when you break down the transfer, or you break down their gait. Let's say they're up on toes, and then You can measure their heel distance from the floor when walking or when standing. Get some type of measure that might not be our classic measure to demonstrate there's an improvement. And then make sure you're focusing on functional mobility and skill acquisition, and also being aware of the best biomechanics of these skills. You want to be a good describer of alignment, the quality of movement, their strength and range of motion, and will assist when you're noting objective changes. Even though the description of alignment and quality can be often more subjective and not as objective as range of motion, to be honest, in children, they are not as compliant as adults. So some of our findings are a little more subjective, like range of motion with the torticollis patient. Oftentimes we try to use a goniometer, but they're moving. So it's sometimes also an eyeball measurement at that point. Consider breaking down components of a transfer. I said that earlier, to what the assist level at certain stages, like transition from sit to stand. Child needs moderate assistance to initiate, but then minimum assistance to complete. And then a rate of objective change is often not as quick with congenital issues as with acute injuries. So that's to keep in mind. They're not going to move as fast. Oftentimes our prescriptions, we go for 3 months to allow the child to go through some development, and then also it helps us as a therapist to really get to know what their ability is, especially if they're a total body involvement or a complex patient where there's cognitive and behavioral issues. And considerations when you are doing your assessment. You try to summarize what is limiting the child's mobility and gross motor skills. You're trying to consider, is there range restriction, strength limitation, lack of coordinated control? Is it motor planning? Is it lack of appropriate sensory input? I'll go over some children, the delayed milestones, lack of coordination kids. They often have vestibular and proprioceptive issues. Kids with CP will have vestibular, proprioceptive, and visual, but you can't always do the standard tests. You have to do more observational on them. Like you watch them when they swing. How do they respond in regards to swinging? Do they have a startle reaction? And then proprioceptive, are they stomping their feet when they walk? Are they unable to control their limb and space? That could be because of poor coordination, but it also could be, proprioceptive most likely is also involved. And then visual, obviously if they have nystagmus or tracking difficulties, they have visual impairments. If they don't seem to look at something that you offer them, those are components you need to think about. And oftentimes you're making a hypothesis in your first assessment. So you may use things like a possibly or appears to, because it's not until you begin to see that child more often can you really go, you know what, that is because of lack of proprioception or lack of sensation, that you're able to more clearly do those testing. And then in your assessment and plan of care, make sure that you're including the family's goals for the child as best you can ascertain. They may need guidance because oftentimes they'll say, I want my child to walk, and they can't sit. So you need to help break down the goals or steps for them to get there and talk to the family about that. Make your goals as functional as possible and with as many objective measures as you can. And I try to include some about the quality of movement, then also try to include range, and then assistance level. I try to hit all those areas so I'm not just all range of motion or all strength goals. And then you need to be a good describer of biomechanics and the quality of movement. And this will help you in all aspects. If your observation skills and how a person moves, not only normally, and then with these children, oftentimes they move abnormally. So if you can relate what a normal child at that age should be doing, then you're much better at describing that, and it will help you in your justification for need for skilled, because pediatrics is one that is, I would say, high intensity from the therapist often, because you are treating the child and the family, and not always high reimbursement or because of the intensity required. And then also you have insurance companies putting more and more expectation on documentation to justify more services too. And then I wanted to include questions for plan of care and prognosis development. I get questions all the time about prognosis, and I put out 5 questions that I think would help you in deciding the prognosis. You want to identify which category, and I'm going to go over those of the categories that most children fit into, other than those that have had traumatic sports injuries. So these are a category of either a neurologic, a musculoskeletal, or a delayed milestone or lack of coordination. Is their condition complex or simple? Complex involves multiple joint, cognitive, behavior, all those things would be included in that. Simple condition would be 1, maybe 2 joints, and little to no cognitive or behavior impairment. Is their condition or insult progressive or stable? Progressive condition is any condition that involves slow degeneration of a system, like muscular dystrophy, spinal muscular atrophy. Stable or non-progressive, that would be your, there was one insult, one injury, damage is done, and so it's not progressing. It's not like multiple sclerosis or one of those conditions. It is like they had a grade 4 bleed right after they were preterm. They were 32 weeks, 31 weeks, and they had a grade 4 bleed while they were in the NICU due to saturation level changes and gas changes that they had a bleed. But that happened then, and now it's just the recovery of the neurologic system and the muscular system after that injury. Then also, you want to identify, do they have the gross motor or functional mobility limitations, and what are they? The more they have, the more difficult, the poorer the prognosis. What is causing their gross motor or functional mobility limitations? The more things that are causing their limitations, because you could have passive range of motion, active range of motion, weakness, decreased coordination, lack of proprioception, lack of alertness, lack of vestibular vision. All these things the more on the list, I tried to list as many as I can, the poorer prognosis for outcome. The less on the list, the better the prognosis. And I give this just as a guideline, because when they're young, and their neurologic systems are still recovering and healing, things that you think they're going to have a lot of difficulty with, they may unfold and no longer have difficulties as they get a little bit older. Like especially if they're real agitated and they've had other drugs in their system or something that they're trying to recover from. Once they're medically a little more stable, you might see some of these issues resolved. So you need to be considerate of that. So I went over that prognosis and treatment planning. And you really want to focus on what is the priority for increasing the child's function, and try to focus on what the family wants. However, if they ask for walking and they're not sitting, and it's appropriate to work on sitting for that age, You want to break down the steps for them and let them know they need to be able to do this before we really focus on walking. And as a child gets older, like 2 or 3 years old, you're or even 18 months, 2 years old, you're going to be thinking about adaptive positioning for them to function. You may be thinking of different type of walkers to allow them to walk that full support walkers. Uh, but to be honest, I feel like that is an entire course in itself on what to do with that. And in your treatment planning, what strategies you try to think about in your first session, what strategies or activities can you simply implement to make an immediate change. Torticollis, I'll tell you the easy way to make a change. You tell them to buy little head positioners that look like bananas, keeps the head straight in the car seat. There you go. That's your treatment strategy. In our clinic, we have them available, and the majority of families will purchase them immediately. That's your first little instruction, and then obviously range of motion, passive range of motion, active range of motion to address the tightness of the sternocleidomastoid. And then you're asking yourself, do I have parents that comprehend the diagnosis? Do they see the value of the service, and will they participate? If the physician is sending the referral, family has a good rapport with the physician, they may do whatever you say. But if they do not, they may question the referral, and you may have to give more explanation of why they need intervention, and if they even need intervention. But just be aware of that. And then you're thinking about, does the child need DME, splinting, orthotics to help his function? It does not have to be on that day, but you're considering in your mind, gosh, would a medial arch support help the midfoot pronation? Would an SMO, an AFO, what would help them? So you begin to just make notes in your mind, and you may make it in your assessment that you're going to be looking into that. Would a walker help them? So those are all your consideration. I'm going to go ahead and pause this part, take a drink,